Hello, so this video is about bipolar spectrum disorders. This will be the first video of a few. So if you're following along with your handout, we talk about bipolar spectrum disorders are disorders in which mood swings vary. They go from depression to euphoria. They can do that very quickly, but also have some normalcy there in the middle. So remember that this is a spectrum of disorders, so not everyone acts the same way. You're not going to have the same behaviors or the same level of behaviors from every individual. So there are different types of bipolar disorder. So this is helpful to understand that bipolar 1 disorder is really the only type of bipolar disorder in which the patient can reach all of the extremes. So they can have clinical depression. In fact, they need to have clinical depression, and although the primary way that it's diagnosed is by a full-blown mania episode. So your patient can have just had a full-blown mania episode and they would have bipolar 1. So this is the only one that reaches the top extreme. But they also reach that bottom extreme. So they're the one that has the full spectrum of mood swings. Bipolar 1 disorder can also have psychosis. So they can have a psychotic, manic experience. We don't see that a whole lot because patients are generally medicated, but that can happen in this population only. Bipolar 2 disorder is a little bit different. So the patient does not ever get to the full-blown mania. They get to what we call a hypomanic episode, and we'll talk about the symptoms here in just a few minutes. So they can have severe depression, but they never get to a full-blown mania. So their kind of top level is hypomanic. Cyclothymic disorder is more of, they consider it more kind of in the middle ranges. So the patient can have moderate depression, they can go to hypomanic. The other very clear distinction is that in order for this to be diagnosed, the patient has had to have symptoms for 2 years. So these symptoms tend to be less profound, and so they have to have them for a longer period of time before they're diagnosed with a mental illness. And then there are a few specifiers. We have those that rapid cycle. So that means that they tend to go from periods of depression to periods of hypomania. They have lots of episodes in a particular year. The other one that is of particular importance is a mixed episode. So when a patient has a mixed episode, that means that they have symptoms of the depression type side of bipolar disorder, along with the hypomanic or manic side of bipolar disorder. This can be extremely dangerous because now we have patients who are not only potentially suicidal, but they're also very impulsive, have racing thoughts. So they can, the last thing that we want is an impulsive suicidal patient. That's a very high risk for suicide. The etiology is really unknown, as it is for most of these issues or mental health issues. It's a very strong combination of genetic factors. There's neurobiologic issues, so there's lots of neurotransmitters, hormones that are thought to be problematic. There's also psychological influences. They feel that some of the neurocircuitry in the brain has become degraded. There are psychosocial influences, as well as looking specifically at norepinephrine, serotonin, dopamine, excess. So generally when we're thinking about, especially manic behaviors, we're thinking about excess of these neurotransmitters. So as we discussed, there is a continuum of symptoms. And when a patient is considered having hypomania is when it's really not severe enough for the person to be hospitalized. There's not a severe enough marked impairment, but they tend to be very cheerful. They tend to be, very social, wanting to be your best friend, but there's an underlying irritability to it. So this is somebody that can turn on you very quickly if you confront them. They tend to be very flighty, extroverted, social, but with a lack of depth in friendships. And so when you get to go to the psychiatric unit, you may see somebody who comes up to you and wants to be your best friend type of thing, and gets upset when they're told that they need to, back off of the students or whatever. And that's generally somebody who's kind of hypomanic. They also tend to talk loudly. They may say things that are very inappropriate at times. It may have some inappropriate behaviors, but definitely not to the level of a manic patient. They do tend to have an increased appetite for food and sex, which just tend to cause problems. Acute mania. So a patient can have acute mania, or what we call full-blown mania. That can either be progressive, meaning they start from normal to hypomania to mania, or they can just go from normal to a manic episode. Doesn't have to have the hypomania there first. So they are euphoric, they're high, they are generally easily agitated or angered. So again, somebody that will switch moods. We use the term labile. So they're not stable in their moods, they're labile in their moods, which means their mood changes very quickly, very rapidly. Very easily distractible. This is where we see the flight of ideas, which, remember, is the very rapid switching from topic that you can kind of follow. Pressured speech, where they're just trying to get the words out so quickly that their mouth can't keep up with them. And you can see hallucinations and delusions here, as well as definitely a decreased need for sleep. These patients do not sleep much at all, which is of very high concern. Delirious mania. So again, this is the psychotic mania. This is where we often do not see patients anymore, but they could get to this state. They're very clouded, confused. They can have movement that is purposeless. So we call it purposeless movement is a safety issue because you don't know what they're going to do next. It's hard to predict. Very labile, stupid, frenzied, can go from despair to ecstasy very quickly. So safety is really our number one concern here. And then any type of mania, hypomania, full-blown mania, or acute mania, and then psychotic mania, they all tend to have poor judgment and impulsivity. And so those are the things that we really have to watch. We have to often make judgment calls for these patients and ensure that we're protecting them from their impulsive behaviors. We have to watch them very carefully. So here's it's kind of a side note. It is something I do want you to know. It's not in your textbook, but we talk a little bit about adolescents and children, ADHD medication, along with having bipolar disorder. So a child or adolescent can have both ADHD and a bipolar disorder. They do have to have, in order to be diagnosed with bipolar disorder, they have to have a much increased intensity and frequency, severity of the symptoms, because they can mimic one another at times. And so the amount of symptoms and the length that they have them has to be longer to meet the criteria for bipolar disorder when compared to adults. Often, this is the first time we really talk about it, but often it is very difficult to tell mental illness in children. The younger the child, the more difficult it is to determine, because so much of normal childhood behavior, if an adult did that, would be considered mental illness. And so it's very difficult to distinguish normal childhood behavior from mania at times. And those of you that are home with your children can probably appreciate that your children may be getting a little manic at times. So the treatment, when we treat children with bipolar disorder, whether or not they have ADHD or ADD, we want them to have a monotherapy, meaning that they're being treated with one medication. And so they will try a lithium, they will try an anticonvulsant, they will try an antipsychotic. And if one of those does not work, they will try switching them to another one usually. Where adults, if one works a little bit, they might add to it. And so they'd be on multiple medications. With children, they try monotherapy as much as possible. The other piece that is important is that if the child needs to be on a stimulant for ADD or ADHD, they really need to be on monotherapy. They need to be on their mood stabilizer for several weeks first. We want the mood stabilized before they're on a stimulant. Otherwise, that stimulant can actually push them into a manic episode. Family interventions with children with bipolar disorder is really focused on psychoeducation treatment, and which can help reduce relapse. So when we talk about relapse, we mean with any mental illness, not just alcohol, and an increase in medication compliance. So you're going to hear that said several times this semester, that we want families to be involved as much as possible. They can help identify symptoms. So if the patient is starting to go downhill again, the family often identifies symptoms first before the patient even realizes it. So that's a very important piece in preventing relapse. Also, they can help with compliance. They can help set the patient up for medications. They can help ensure that the patient is taking the medications. So some of the things that we see that we have to be carefully watchful of are some of the behaviors. So there's nonstop physical activity. Lack of sleep and food can cause physical exhaustion and death if it's not treated. So the lack of sleep, the increase in lack of food, and the increase in physical activity can be considered medical emergencies. And we have to keep that in mind. Those are of utmost importance to treat in these patients. Patients will push limits. They can find that inactivity is actually impossible for them to do. And think about how you are when you don't sleep. So these patients are now going without sleep because they feel like they don't need it, but doesn't actually mean they don't need it. So they feel like they don't need it, and then their cognition gets poorer and poorer as they progress and move on without their sleep. They also tend to have very poor personal boundaries. So these are patients that will get right into your bubble. They will talk to you about things that are inappropriate, ask you questions that are inappropriate. So we are the ones that need to make sure that we're setting those limits. So please make sure that you're treating these online lectures just like we're in class. So I am going to have you pause it right now. I want you to read through the case study that starts out with Mr. Adkins. This is a continuation of the case study from your advanced organizer. So if you need to review that, please do. And I want you to please jot down your answers first before listening to the answers. It's only going to hurt you if you don't. So please go ahead, jot down your answers to this initial part of the case study where we discuss why the decisions were made and if they were the best approach. So please do that now. So hopefully you're coming back now from jotting down your answers. And, Mr. Adkins, was feeling uncomfortable in the situation. He has talked with his peers about what they think, should be done. And he definitely should not be put in a situation where he is starting to feel uncomfortable or where he could be accused of doing something that he didn't do. So the correct decision was made, and they have figured out how to handle, the patient having male staff. And, sometimes we ask the question, well, why not just completely remove that patient from care? Well, we do need to be able to monitor how is that patient doing with male staff. And we do need to challenge that patient a little bit to be able to do the things that she needs to do in order to control herself, to be able to watch the progression of her illness. So we need to do that in a very safe environment that does not put any of our staff at risk. Okay, the next piece here, again, is another activity. So if you turn to the last page that goes along with your bipolar disorder, you'll see assigning nursing diagnosis to behaviors commonly associated with bipolar mania. So what I'm going to have you do at this time is you read through that short case study. Just at the top there, you're going to see that I've already filled in the behavior. So these are the behaviors that you're seeing. I have a nursing diagnosis for you. And what you want to do then is write up 2 or 3 interventions for each nursing diagnosis. What do you think that you should do and why? So you're going to put your rationales in there. So please just make sure that under each intervention that you're paying attention specifically to the behaviors that you're addressing with that nursing diagnosis. I'm going to end this video here, and I'll have a video discussing those answers. So please work on those.